Hi, I'm Tony Mecham. I'm an oral maxillofacial radiologist, and this video is a review of Intraoral Radiographic Anatomy. This is meant as a review, so not for first-year dental students or anyone who hasn't already had some exposure to radiology anatomy. I'm specifically making it for my second-year course, which is an interpretive course, because what is paramount to interpretation is recognizing anatomy. So you have to know anatomy to recognize what's abnormal, and then we'll get into describing, and then we'll get more into the interpretation of lesions. This is my reference material. So my go-to is White and Farrow's Oral Radiology, and the anatomy chapter is chapter 12. But all of these books have great chapters on intraoral anatomy, so I highly encourage you to read each of those and look at the different examples that they have. First, I want to talk a little bit about this geographical principle, the eggshell effect, which is something that occurs on corticated structures. As I get my pointer out here. As you see, this is a radiograph of an eggshell. And why does it have this thin radiopaque line around it? It's not that the shell is any thicker in that one place, but as this diagram shows, the x-rays pass tangentially through that point. And so relatively it's going through a thicker portion of the shell than it is when it passes at more of a 90-degree angle. And so this accounts for the thin radiolucent line we see around things such as the lamina dura, the alveolar crest, borders of sinuses and nasal cavities. So we'll show you all of those in this anatomy review. It also, as far as pathology, this is what creates the corticated walls of cysts and tumors. So a little thought question for you. Are you going to see this on a soft tissue structure like the tongue? No, you won't, because it doesn't have a cortex around it. So if you ever see a cortex around something, don't guess that it's a soft tissue structure. And it's also something that helps in our diagnosis when we're talking about more benign things. If it shows this corticated wall around it, it's more likely to be something benign. And so, as I said, the eggshell effect is what creates this lamina dura, because you can think of it as a cortex around the tooth outline. And so as the x-rays pass tangentially through that thicker part of bone, it creates the eggshell effect, and you have this thin radiolucent line. And now there's a lot of variation. You see in some cases that lamina dura is fairly thick. In some cases it's really thin. And that's all just within normal variation. Here we see a remnant in a tooth socket, so the remnant of the lamina dura. So it's not always going to be completely discernible, but when it is, it's nice because then you can see the outline of the PDL space, and you can easily rule out a periapical inflammatory lesion. All right, the alveolar crest, to some degree, it's also corticated. You see this one appears more corticated here on the mandible. But these look healthy. So as long as you have this nice, fairly sharp angle, it follows the contours of the tooth, and then it goes relatively straight across, at least for posterior teeth, and within 2 millimeters of the CEJ. That's considered normal. So what happens with periodontal disease, you start losing that alveolar bone. And so if it's more than 2 millimeters, you can surmise that there's likely some degree of periodontal bone loss. And it should be nice and continuous with the lamina dura. I mentioned that angle that you see, not always a right angle, sometimes more acute, sometimes more oblique. But if it's continuous with the lamina dura, that's a good sign that there's not at least active periodontal disease. All right, refer back to this kind of well-known literature way back in 1991, where they did the studies and found that with a 95% confidence interval, healthy CEJ to the alveolar crest distance was between 0.4 and 1.9 millimeters. So anything beyond 2 millimeters, as I said, you should start thinking periodontal disease. All right, cancellous bone or trabecular bone, what you're seeing here is the marrow spaces. So the marrow spaces are the less dense, the fatty material that's inside bones, and the trabeculation is these radiopaque lines. We'll see a difference between the maxilla and the mandible. The maxilla has more fine trabeculation, small spaces, whereas the mandible has more thick trabeculation, but more sparse, larger spaces. So they're more spread out in the mandible. And there's a lot of variation in the mandible, especially in the body of the mandible. Here I see a lot of times where it just looks really radiolucent, and that's just anatomical variation because I don't really know the reason. Some cases it may be osteoporosis, but some people just don't have a lot of dense trabecular pattern in that area. All right, now to focus specifically on the PDL space. Just as we said about the lamina dura, the PDL space can be wider or it can be shorter. It can show up really well all the way around the root, or it can kind of disappear somewhere around the root, wider on this side. A lot of times you'll see it wider with physiologic movement, so orthodontic movement, or if there's parafunction on one of the teeth, it can be wider in one area more than the other, or just chalk it up to anatomical variation. A little trick question for you. So which of these lines is the PDL space? Great time for this meme. How about both? Yeah, if you have a hourglass shaped where you have a double curvature of the root, the X-ray beams can pass tangentially through both sides of the PDL space. So one's on the mesial, one's on the lingual. Both of those are PDL space. They both appear healthy, so nothing wrong with that one. All right, now we're going to focus on individual structures inside the maxilla. And I'll give you guys a chance to see if you know it before I give away the answer. So test your metal. See if you remember what this is. We're talking about the thin radiolucent line that extends, where is this? It's in the anterior maxilla, right in the midplane, so between the two central incisors, and this is the intermaxillary suture. Next one, so when you're looking at a radiographic image, we're talking about this V-shaped opacity right here. Sometimes it stands out. Sometimes you don't get high enough to see it, so you have to see fairly far beyond the apices of those central incisors. Here I show in my skull that kind of pointy protrusion where some of the cartilage of the nasal septum attaches, and that is the anterior nasal spine, the ANS. So now we're looking at going kind of laterally from the anterior nasal spine, ascending upward. Here the arrow is pointed out in the skull. That makes it kind of apparent, right? And so that's just the opening of the nasal fossa. And this one right here is a different one. We're talking about this. It looks more like a soft tissue structure. And there is soft tissue around it, although there's a bone inside of it. This is the inferior turbinate, or concha. And here when we're talking about the middle part, there's a bony part of it, so you can see there's some osseous section in here, and some soft tissue around it. And so this is all part of the nasal septum. So we had a nasal aperture, or opening of the nasal cavity, however you would want to call that, the nasal cavity. Then we had our nasal concha, or turbinate, and then our nasal septum. What are we looking at here? And sometimes you first need to orient yourself by looking at the teeth. You need to know which part of the mouth you're looking at. Here we have anterior teeth. There's a central incisor, lateral incisor, canine. And so you're going further posterior or further distal in this direction. This is the left side. It's always as if you're looking at the patient in a radiograph. And so here, more toward the midline or more toward the anterior, this is still going to be your nasal cavity. And we'll show this again, but it does show it here. You start to see this inverted Y. They call this the Y line of Innes. This is where you start to see the maxillary sinus back here. And so again, orient yourself in this image, what you're looking at. You have premolars here. You have a missing molar and then a second molar. We're looking at the patient's right side because again, it's as if you're looking at the patient. And so if I see his molar back here, premolars up here, this is his right side. We see the maxillary sinus dip down in between. And occasionally you'll see high enough, I guess, far enough up into the image in one of these posterior periapicals that you'll still see the floor of the nasal cavity. It'll look more like a straight line, like this. So both of these I would just call the nasal cavity. This one is still kind of the anterior opening or the aperture of the nasal cavity. And this is more descending posteriorly or extending posteriorly. You could also call this the hard palate line because those are like two sides of the same coin. You've got your hard palate or your nasal cavity. All right, now these arrows are trying to point out this radiolucent kind of oval in between the roots of these central incisors. Looks pretty well defined. Sometimes it's more visible than others, just variations in patient's anatomy. This one is pretty visible and fairly large. In this one it's less visible, but you do see it overlie the structure of the root. And so that's not root resorption. It's not anything going wrong with the root. It's just a different orifice that's overlying that root structure. And so this is the incisive or nasopalatine foramen. So this is the inferior opening of the nasopalatine canal, which we can call the incisive foramen. So here, extending superiorly from the nasopalatine foramen is the nasopalatine canal, or incisive canal. And this just shows in a CBCT. I know a lot of you haven't been exposed to CBCT yet, but I like this because it shows a three-dimensional representation of where these structures are. You see anteriorly here, the central incisor, and the nasopalatine canal lies pretty far toward the palate of the roots. in most cases. A lot of times the orifice, the opening, the incisive foramen will even overlap some of the roots of the central incisors. So Nasopalatine canal. All right, here we see two distinct radiolucencies. This is kind of a steeply angled radiograph. You can tell this is an occlusal radiograph, not just a periapical. And so they got a lot further back. This is taken from above, and I kind of simulated the angle when I took this photo of the skull to show that. On either side of the nasal septum, you have these two orifices, these two openings, which are the superior foramina of the nasopalatine canal. So in most cases, when you see one of the foramina, it's going to be the inferior one, and that's in between the roots of the central incisors. At least it projects radiographically in between the roots of the incisors. But if you get a really steeply angled radiograph, you can sometimes see the superior foramina of the canal. Okay, here we're pointing out this radiolucency that kind of surrounds the apical portion of the lateral incisor. Sometimes this can simulate a periapical lesion, even though it's not, it's just an anatomical structure. And so here I outline it for you on the skull. And just like most things, in some patients it's more pronounced than others. And you may see a little fossa here. Sometimes it extends more over the, in fact most times it extends more over the lateral incisor apex. And so we'll just call that the lateral or incisive fossa. So a fossa just meaning a depression in the bone. It creates a radiolucent appearance because having a depression, there's less bone thickness there. Okay, if you look at this radiopaque structure and you start thinking, okay, is it a cyst or a tumor or something, or is it an osseous structure? All those things will have a cortical outline around it. One good way to tell that it might be, at least, it might be a soft tissue structure, is there's no cortical outline around it. It's pretty much uniformly radiopaque. Sometimes these soft tissue structures, they can be fairly thick and dense, and so they can block out some of the radiation and appear fairly radiopaque. And this is just the soft tissue of the nose. Here's an image angled down at a nose showing how you'd have to have kind of a steep angled radiograph to project the soft tissue of the nose over the radiograph. But a lot of times you do that in anterior periapical radiography. So you'll see that. You'll see the soft tissue of the nose. If you see it more laterally, you may see the wings of the nose, the ala of the nose. Now, this is an interesting one because it's not something you're going to see very commonly in intraoral radiography. We see here another occlusal radiograph. See how you see all the maxillary teeth together, at least to the second molars. And it's taken really steeply. Again, these occlusal radiographs, which aren't done that frequently anymore. Now we all kind of opt for 3D imaging with CBCT. But if you take a steeply angled periapical, you may see this structure as well. And this is actually the inferior opening of the nasolacrimal duct. Nasolacrimal, so it drains the tears into the nasal cavity. And you can imagine if you take something steep enough, that'll project that over that part of the palate where you can see it in an occlusal radiograph, or in some cases in a periapical radiograph. Although, as I said, that is somewhat rare. All right, corticated structure here. We see that eggshell effect. We got this thin radiopaque line. We know it's likely going to be some osseous structure, some bony structure. So what we're showing right now is anatomical structures, and this is the maxillary sinus. A lot of times it will dip down in between the roots of maxillary molars. So you see that. It can even dip down in between it and go way down between the molars. It's just a lot of variation, and that sinus continues to grow. It continues to pneumatize over time. All right, as promised before, I said I would show you this inverted Y-line, or the Y-line of Ennis, it's called. So what do we have here? Orient yourself to the radiograph. Canine right in the middle. Nice canine shot. This is an incisor, so this is more anterior, so you should suspect that that line is the nasal cavity, the floor of the nasal cavity. It continues onward, as we showed. In some cases you can even see it in the posterior, but that's rare. And so what would that make this? Extending posterior over the roots of the premolars. This is the maxillary sinus floor. And sometimes they meet together and form that inverted Y. In a case like this, they look like they cross and they form an X. But irregardless, it's all the same structures. The sinus border just continues upward here, and the nasal cavity border continues back. You'll probably see that image again when it'll come up again. Okay, so what are the maxillary sinuses? I know you are familiar with them, and as a dentist, you're going to be very familiar with them. Air-filled cavity lined by thin mucous membrane. In health, that mucous membrane is going to be very thin. Sometimes you'll see that that membrane is thickened, and so they have some degree of mucositis, and it'll show up on radiographs. It does occupy a majority of the maxilla, although that varies person to person. Some people have very small maxillary sinuses, but in most cases, it's fairly well pneumatized, and it occupies a big degree of the maxillary sinus. It's pyramidal with the base at the bottom, or the base of the medial wall. The apex is extending outward toward the zygomatic process. We're going to talk about that because that's my favorite anatomical structure. So know that word, zygomatic process of the maxilla. They should, in health, show a thin cortical line like we've shown you in some of those examples that you've already seen. All right, a couple other examples here of the maxillary sinus. I said in a lot of cases it will dip down in between the roots of the teeth. Here they've also got a periodontal lesion. Obviously that's more than 2 millimeters. And so they've got this vertical periodontal defect here. And so now all you're left with is a single cortex of bone separating that periodontal defect from where the maxillary sinus is, which is right here. And then we'll get to these structures in a minute here. This one may be kind of tough to recognize even what you're looking at because we don't have teeth, but it looks to me, because I see this structure and I know what it is, and I know that extends posteriorly in that direction, so toward my right. I'm looking at the patient's left side, and this is their anterior toward the left, and their posterior toward the right here. And so this is the maxillary sinus. Fairly large. As I said, it continues to pneumatize over time as patients age. So what would this be? Is this the posterior border of the sinus? Well, no, the maxilla continues backward here, and the posterior border of the sinus is not going to be until you see the posterior part of the maxilla, the posterior of the tuberosity. And so this is just a septum, a sinus septum. Not uncommon to see septae, just little flat walls of bone inside sinuses, including the maxillary sinus. All right, this is what I just mentioned there, a septation inside the sinus. No, it's not a endodontic file. This tooth does not have endodontic treatment, but you have the sinus border here. The sinus border continues on here, and so that's just a sinus septum. What if you have a radiolucency? Would that be a septum? Hopefully you know that no, septae are going to be opaque like that. That's a septum. And so if you see a radiolucency, what could it be? Well, it could be a neurovascular canal. And you do have the posterior superior alveolar canal, the middle superior alveolar. You have these different canals going on the lateral surface of the maxillary sinus that it's somewhat rare, but you may see those extend across the border of the sinus in your radiographs. There are your answers. All right, here's my favorite slide because it's my favorite structure. What are we getting at here? What are these black arrows pointing to? If you learn one thing from this lecture, learn this one. It is the most important anatomical structure. It's the zygomatic process of the maxilla. So, okay, here's where I outlined it. I drew this yellow line on my skull, trying to show that that kind of saddle-shaped appearance is where the x-rays come in tangentially, and that's what creates this U-shaped appearance. So that's your zygomatic process of the maxilla. We see the red represents suture lines, and so this is all still part of the maxilla, that part that makes that U-shaped structure that we just pointed out on the previous slide. But this U-shaped or J-shaped structure comes from part of the maxilla that we call the zygomatic process of the maxilla. That's where it gets its name. That's how it gets that appearance. And so these are the sutures showing the zygoma. So the zygomatical maxillary suture, zygomatical frontal suture, and zygomatical, what's this bone that makes up most of the zygomatic arch? That's actually the temporal bone, actually makes up most of the zygomatic arch. Really only the anterior third of the zygomatic arch is the zygomatic bone itself. All right, so if these arrows are pointing to the part extending backwards from the zygomatic process, what is it pointing to? Look at the skull. Looks like it's pointing to part of the zygoma. And this, it's really close. If I'm trying to point out the zygoma, I'd probably point back here because I know this whole area right here is part of the zygoma. If I point out this U-shaped structure, I know that it's that right there. It's the zygomatic process of the maxilla. All right. What are these arrows pointing to? We see this radiopacity as you look further distal here, further posterior in the patient. Kind of hard to tell, but Just kind of knowing what this is, it can orient me to which direction this is. You can also see the maxillary sinus back here. So you could surmise that this is the left side of the patient. So that's posterior, this is anterior. This looks like a premolar here, probably a first premolar. And so what's creating that line? Is this a bony structure? Does it have a cortex around it? No, it just looks uniformly radiopaque, most likely a soft tissue structure. And that's what we're seeing right here. This image shows it really good. The nasolabial fold. Most anatomical things, if you think, okay, where does it come from and where does it go to, you can name it. It goes from the nose, kind of to the lip, the corner of the mouth, nasolabial fold. And those will show up on radiographs. All right, what are we pointing at here? Here we have the maxillary tuberosity. We're looking at a right molar. I know that because I see the tuberosity here, so this is posterior. This is going to be more anterior. I see 2 molars here. So what's this plate that extends posterior to the tuberosity? That would be the pterygoid plate. And I guess if I asked, was it lateral or medial? The lateral one is larger, it stands out more. Here you can see the lateral pterygoid plate. It's larger, it's fairly bulky, although it is fairly thin. But typically what you're seeing is going to be the lateral plate. And so here's another arrow for you. What is that pointing to? This little kind of hook-shaped thing that extends downward. And we're pointing at the same thing with the pencil lead here. Some little hook-shaped thing that extends distally. Probably that's what you're seeing right there as well. This is the hamulus, and it extends off the medial pterygoid plate. So if you can see there, it kind of attaches more medial. It's the hamulus. It's rare to see that in a radiograph, so always exciting when you see a hamulus. If any of you see that, send it to me for an example. Random anatomical structures that we can focus on. All right, that's it for now for the maxilla. Let's move on to mandible. This is another occlusal. I know these are all outdated. Nobody does occlusals anymore. We look at this in 3 dimension, but we're looking, think of it looking top down onto the mandible, or really maybe you're looking bottom up because you always want your eyes to be like the where the x-rays are coming from. And you have this projection of bone that's projecting lingually. This is what? This is not an osseous structure. There's no cortical border around it. This is the tongue outline. So this is projecting lingually. And we're seeing the chin out here, kind of the front of the chin. So this is the front of the patient. So extending lingually is this projection. Very pronounced in this patient. This grows over time. This is the genial tubercle. This grows because there's fairly strong muscle attachment, typically the genial hyoid. Typically the genial glossus, because your glossus, like that's the big, strong muscle, right? But also the genial hyoid can form other tubercles inferior to where the genial tubercles of the genial glossus pull. And so it is from muscle pull. It can be, usually it's around another structure we're going to talk about in a minute, which is the lingual foramen. So remember, foramen, it should look radiolucent. If I'm talking about tubercles, that's a projection of bone. A spine of bone is a sharp projection of bone, so you can call it a tubercle or a spine. Mental, just meaning the mentum region, the region of the chin. And as promised, if you have this small round dot radiolucency, usually right in the center, there is some variation of this. Sometimes you'll see several lingual foramina. A lot of times you see the genial tubercle pull kind of around the foramen. In this case, it's more inferior. But if I specifically say, okay, what is this round radiolucent dot, then you know it's the lingual foramen. You can see a little foramen here. Sometimes a lot of accessory foramen, so a lot of variation to that. All right, you see this. Does it look like a bony structure or soft tissue structure? It's kind of hard to see the cortex. The inferior mandible, remember the cortex is really thick. So actually several millimeters here is probably the thickness of the cortex. That's why we're not getting that nice thin eggshell type effect, but you still see it because you see the thickened cortex here. Compare it with on the lingual here, very thick cortex. And so this sometimes you'll see when you take a steep anterior mandibular radiograph and you just project that ridge of bone over the radiograph. And so that's called the mental ridge. Again, the mentum region, mental ridge. So if you see that projected in the anterior mandibular radiograph, just the mental ridge. All right, what would this be? Remember the term for this when there's a depression in the bone? What do we call that? That's a fossa. And in some cases, those will show up as a fossa in the anterior mandible. So if it's a radiolucency, but you don't suspect a periapical radiolucency because the PDL spaces are intact, doesn't really look like pathology. I still see good trabeculation. The lamina dura remain intact. This is why we need to know these different anatomical variations. And so there can be a depression here in the bone, which we're going to refer to as the mental fossa. Always reminds me of mental floss, mental flossing. So mental fossa. All right, you see this round, well-defined radiolucency. Are you going to suspect that that's periapical pathology? Nothing wrong with that premolar. This one does happen to align right with the second premolar apex. This is the same thing over here. In most cases, it's going to be further inferior than the apex, but it can superimpose over the apex of a tooth, anywhere from the first premolar to the mesial root of the first molar. But usually it's going to be around the second premolar where you see this. Hopefully you know this one, mental foramen. So don't mistake this for pathology. Don't mistake it for an inflammatory lesion. Always be on the lookout for the mental foramen. You'll see it a lot and you'll get used to it. All right, what do we have here? This one's interesting because it almost looks more opaque than a canal. If I told you this was a canal, you might ask, well, why isn't it more radiolucent? Most canals are. Notice it does have some cortical bone around it. Maybe that adds to the kind of radiopaque appearance of the canal in this case. But yeah, in most cases, the canal is going to be radiolucent like this. And so what canal is this? You can call it the mandibular canal or inferior alveolar canal. You'll see that. So that leads anteriorly and then branches to the mental branch. That's where you get that mental foramen that I just showed you. That's going to be around the premolar region. So this is a good kind of comparison here to show two different appearances of the canal, one that's more opaque than the other. And here we see other little canals running superiorly into the apices of the tooth from the mandibular canal. We would just call that, again, neurovascular canals, or a lot of times they call these nutrient canals, especially for some reason in the mandibular anterior. So I'm okay with either of those terminologies. This one, they stand out really well because there's so much infection. Look at the degree of periodontal bone loss. And so you see all these different nutrient canals, these neurovascular canals. And so you'll see that sometimes in the anterior mandible. Not uncommon to see this in the posterior mandible, where they've got kind of a thick cortex around it. And then so sometimes it just looks like a radiopaque line streaking from the apices of teeth. But those are just nutrient canals. All right, here we have a ridge of bone extending from the anterior border of the ramus and kind of along the lateral buccal border of the mandibular body. You know the name of this one? This is the external oblique ridge. Think of it as external to the mandible. It's on the buccal surface. And it runs here posterior. Sometimes it looks like it even crosses the roots of the molars. Sometimes it stands out more than others. And so this one, instead of external, we're looking on the lingual surface, and this would be the internal oblique ridge, or I think more commonly it's named after the muscle that attaches there, which is the mylohyoid. So that's the mylohyoid ridge, which is kind of my default name for this rather than internal oblique. But you can call it internal oblique. Where does this lie in comparison to the external oblique ridge in this radiograph? You know, we can't see three-dimensionally, and so I want to know, is this lingual or buccal, or do I want to know that is this the mylohyoid ridge or is this the external oblique ridge? Remember, the external oblique ridge attaches up at the anterior border of the ramus and then extends down kind of across the roots of the teeth. This one is more inferior. So that's how radiographically you can distinguish between the two. This one lies well above the canal, so the mandibular canal runs down here, whereas this one looks like it overlaps the superior border of the canal. Here we see the inferior border of the canal. Here's the inferior border of the mandible. And my big head's in the way here. But you see there's a lot of variation in how this lines up with the mandibular canal. Okay, now we're looking at a generalized radiolucent appearance, which is right here. So rather than talking about that ridge of a bone, which created more of an opaque appearance, that was the mylohyoid ridge. Now we're talking what's below that ridge of bone. What do we call that? A depression in the bone? That's a fossa. So what would this fossa be? Think of what what salivary gland is right there, the submandibular gland. This is the submandibular fossa. Sometimes it can be really pronounced and create a large radiolucency in that area. And the more and more we look at 3D imaging, we appreciate how deep these depressions can be in the bone. That can make it difficult for implant planning in that location if it really goes kind of S-shaped and curves in and around the submandibular fossa. So a good one to recognize. All right, here the arrows are pointing to, is this a border of the mandibular canal? Well, where's the canal? I see the canal running right through here. This is the superior border. This is the inferior border. And so inferior to that, and beyond that, you have nothing. You have just air, so it's all black here. So this is the inferior border of the mandible. Mylohyoid ridge might be more up here. External oblique ridge. We're running along this way. All right, occasionally you'll see this. Again, this is something I get excited when I see in a radiograph because it doesn't show up that often. I always tell the example of someone I know who was a dentist who saw something back here that looked like a root tip. Do you see how this looks like it could be a root tip? Obviously, we see more of it here, so you wouldn't mistake that for a root tip. But he had planned to go in there and extract that root tip that was left in there. Unfortunately, he took another radiograph, another periapical radiograph, and there was nothing there. And what he determined is it was this structure. And if you take it at just the right angle, what is that we're looking at right there? What's the name of that? Coronoid process. So it's part of the mandible. The temporalis attaches here, helps with mastication. And if taken at the right angle, kind of from behind and superior enough in a molar periapical, you can see that project over the bone. So know that you can see on some occasions the coronoid process. All right, I created this list of 30 structures to know. Obviously, you could know hundreds, but just as a good starting point, I think if you know these structures, you're kind of well off as far as being able to recognize most anatomy that you're going to see in intraoral radiographs. And just a couple other things I wanted to cover because it's important for interpretation. Cervical burnout, especially important for distinguishing cervical burnout from cervical caries. People can get caries on the roots of their teeth when they have gum recession, when they have periodontal bone loss, exposing the dentin to the oral cavity. And so the question is this a cavity? Is this a carious lesion, or is it cervical burnout? And to explain what it is and why it occurs. So I imagine everybody does this as a kid at some point. You shined a light through your fingers, a flashlight, and you saw the red kind of glow. It wasn't the direct light from the flashlight, but it was kind of bouncing around and refracting inside the flesh of your hand. The term for that is subsurface scattering, tough to say. And I think the same thing happens with x-rays, with teeth. And so if you can imagine that, it's kind of creating more of a dark appearance because our radiographs are inverted and we see x-rays as dark. And so where more radiation has reached the sensor, it appears darker. And so if you have this subsurface scattering, it's going to appear darker. The other thing that does that is you have enamel up here. Here I can see the line of enamel. If you remember, if you know dental anatomy, the enamel kind of arches up where you have the papilla, where you have the gingival outline, and then it curves down on the buccal and lingual surfaces. And so that outline of enamel creates a more dense appearance up here around the crown of the tooth, and down here what do you have? What's creating this to look more opaque? You have the bone. And so the bone level, you see curving around the root of that tooth as well. So that's something that adds to it. All these things kind of add to the fact that you just get more radiation coming through right there, and it looks like it does simulate in some cases caries. And so be aware of that. The more and more of these that you look at, the more you'll be able to recognize that this is cervical burnout and not a carious lesion. All right, never make this mistake. I've seen experienced dentists make this mistake. Hopefully it didn't get to the point where they went in and tried to do root canal on a tooth like this. Obviously this one hasn't even erupted, but even after this tooth erupts, this is not going to be gone completely. This is just a developing root of a tooth. And so you can tell the root is still open, the apex is open, this root is still forming, and you have this radiolucent outline around the apex. That's just the bony crypt around the dental papilla. So just forming a normal structure. You're going to see this in kids and teenagers with developing teeth.